Well, one of sort of the seminal issues with older patients is the presence of multimorbidity. So the challenge has become that much more complex because we're not just dealing with a single disease, but we're dealing with multiple diseases and thinking about the interactions of all those diseases, including the multiple medications a patient might be taking. They might make sense for one disease at a time, but when you add up all the diseases and a patient ends up taking 18 medications, 9 of which are interacting with each other, and the patient can't pay for their electric bill because they're spending all their money on medications, that's a problem. So being attentive to kind of the unique needs that arise from the presence of multimorbidity and thinking holistically about the patient and how to optimize their medication regimen in a way that makes sense for the person, not just the individual disease, is critical. I think there's a lot of variability in the kind of what strategies work for different patients. So for example, if a strategy is just focused on getting patients to remember to take their medications more, that can be really useful for patients whose primary problem is just they forget to take their medications, and having improved strategies for helping them, for example, with the medication organizers or reminders. But just to kind of build on that example, a lot of non-adherence isn't due to forgetting, it's due to patients not thinking their medication is useful, not understanding why they're taking it, or having real or perceived side effects and not wanting to take the medicine as a result. So again, we need to be sort of patient-centered in how we approach these things and really understanding what's going on in the patient's mind, why they're acting or not acting a certain way, what's going on in the prescriber's mind, why they're acting or not acting in a certain way, and addressing those levers accordingly.